Welcome everybody. My name is Tiffany Dean and today we'll be looking at compensation strategies for chronic heart failure and the acute and chronic effects these have on cardiac functioning. So first we'll look at heart failure itself, then we'll move into compensation strategies and the effects on cardiac functioning. And finally we'll look at some practical applications for exercise physiologists. But before we begin, the take-home message that I want you to receive is that compensatory methods help increase cardiac output and oxygenated blood flow to the body. But this will result in ischemia, cell death, and fluid retention and affect the cardiopulmonary circulation, as well as the whole body in general. So when we talk about heart failure, it causes a slow decline in blood transfer and oxygen supply to the body system. It affects the systolic and diastolic contraction of both the left and the right ventricles. It's mainly seen in the elderly as well as some children with the signs of cardiac defects. It is when the heart can no longer supply sufficient cardiac output and therefore reduces overall muscle contraction. So when we talk about cardiac output, we're talking about the heart rate in beats per minute multiplied by the stroke volume, so the volume of blood per contraction. So that's what we talk about when we say cardiac output. So when heart failure takes place, there are several strategies that the body does in order to cope with this heart failure dysfunction. So these include the sympathetic nervous system and the renin-angiotensin-aldosterone system, known as the RAAS. We've also got the Starling mechanism looking at preload and the myocardial hypertrophy, so increase in muscle mass of the ventricles. So just before we begin, let's have a look at a negative feedback system. So in a normal setting, when homeostasis is disrupted, such as hypotension, baroreceptors in the aorta and the carotid sinus detect this pressure drop change. They send an impulse to the medulla oblongata to increase the sympathetic activity of the epinephrine and norepinephrine beta receptors. They also slow down the parasympathetic activity. So in cardiac failure, the epinephrine and norepinephrine beta receptors, or these catecholamines, are discharged from the sympathetic nervous system. This will increase peripheral resistance to the extremities as well as myocardial contraction, heart rate, thus increasing cardiac output and venous pressure. So after the sympathetic nervous system activates, the RAAS system steps in. The RAAS secretes renin, a response from reduced blood flow, and produces adenosine 2, which is made by joining adenosine 1 with the adenosine converting enzyme. Adenosine 2 has two functions. It constricts the arteries, so vasoconstriction, and produces aldosterone, which makes the kidneys hold onto fluid and sodium. So this hormone regulates blood pressure and secretes aldosterone to help the kidneys absorb fluid. However, the greater the peripheral resistance and more fluid held in the kidneys, the greater the preload and afterload. So this process is slow and can lead to worsening heart failure. There is reduced blood flow to the extremities, the integumentary system and the renal system, because the blood is diverted to the heart, brain and lungs, so to the major organs. As a result, there's increased urination, there's paleness, cold limbs, hands and feet, and a faint heartbeat that happen. So the sympathetic nervous system activation can have long-term consequences. It will cause further heart failure because when the sympathetic nervous system continues to activate the beta receptors, so that's your epinephrine and norepinephrine receptors, they will over time become non-responsive from being overactivated. This will increase the heart rate, causing the heart to work more, increasing the need for more oxygen. The chronic effect of an overused heart is ischemia, cell injury, reduced contraction, and heart enlargement, which we'll talk about in the next section. So this cycle restricts blood flow to the extremities, diverts more blood to the major organs, and retains fluids in the kidneys, which will imbalance the electrolyte system. Consequently, ischemia, cell injury, and overall reduced contraction occur because of an overworked heart due to unresponsive beta receptors. So this is a great diagram explaining the role of the sympathetic nervous system. So here we've got a cardiac defect that's happened, inducing heart failure, and it's caused the cardiac output to reduce. So the person might feel fatigued or weak. Then we have the sympathetic nervous system, which activates and comes into play. Those beta receptors come in to increase the cardiac output and blood flow. The RAAS system is activated, therefore the sodium holds on to more water. Because the sodium has done this, it'll cause pulmonary congestion and systemic congestion. And the RAAS system also constricts the blood vessels as well. So the person at the end result would have some physical signs of hypertrophy, pulmonary edema, and the rest that's listed. So that's a great little diagram that explains the overall system of the sympathetic nervous system. The next way the heart can compensate is through increased preload, and we can see this in the Starling principle. So preload is the time the ventricles are filling during diastole, when the ventricles are filling with blood. So a great quote to understand this principle is this: within physiological limits, the force of contraction is directly proportional to the initial length of muscle. This means that as the volume in preload rises before a contraction occurs, the heart's muscle wall stretches proportionally, allowing for more force to develop. It's kind of like stretching a rubber band, and as you let it go, it will snap back with a greater force. So as you increase the pressure in the ventricles, so that's your preload, you also increase stroke volume, and that leads to an increased cardiac output and the oxygenated blood flow to the body. So when the heart is failing, the overall blood flow to the body is reduced. This means less goes out to the body and more blood is backing up in the heart. Blood flow to the kidneys will drop, and so the kidneys will hold onto more sodium and water. The volume of blood in the circulatory system that is returning to the heart increases, and more blood enters into the ventricles during diastole, which increases the volume of preload. So this compensating method by increasing preload when cardio output reduces is only temporary. Let's look at left heart failure. As the volume of the blood in the ventricles continue to rise, it will eventually back up into the left atria and then into the pulmonary circulation because there isn't any one-way valve stopping the backflow. That'll cause pulmonary congestion, a long-term effect to preload because of increasing chronic heart failure. So as preload continues to rise, the ventricles have to stretch more to accommodate for more volume of blood filling in. This means that the muscle wall needs to use more oxygen. Eventually there'll be no more oxygen left to use, so the demand will go up, the cells will start to die from ischemia, and the cardiac muscle becomes enlarged, and totally ineffectual. So when looking at this principle, this diagram here is a great example. The y-axis shows cardiac output, and the x-axis shows the pressure in the ventricles at the end of diastole, just before contraction occurs. Line A is a normal contraction, and when the cardiac output decreases, the pressure in the ventricles decrease, moving the curve downwards. So in preload, the pressure in the ventricles increase to increase cardiac output and oxygenated blood flow to the body. Preload will increase blood flow short term, but in long term this process causes ischemia and pulmonary congestion. The cells will die and stroke volume will reduce. And in our curve, it'll start to decrease and go down towards the right. So now that we've looked at heart failure for preload in the sympathetic nervous system, now we'll look at what it does to the heart muscle itself. Ventricular hypertrophy may occur in response to extreme physical exercise, cardiac disease, and cardiac defect. Santoro and his colleagues found that it can happen to anyone at any health circumstance. So unwanted size increase of the ventricular wall will negatively affect the structure and the function of the heart. And it will cause ischemia, diastole dysfunction, and compromise the overall heart action efficiency. Because the ventricle walls have to stretch to accommodate for more excess volume of blood when it's in diastole, the walls become greatly stressed. So this causes the myocardium to increase in size. This affects how the heart contracts by increasing the tension on the ventricle wall, causing damage and harmful outcomes. When looking at the left ventricular hypertrophy, the wall size increases because of an increase in cardiac muscle cells and the number of non-myocytes. So that's your sarcomeres, your macrophages, your fibroblasts, smooth muscle and endothelial cells, as well as your mitochondria. All of these result in a pressure overload response. So in other words, the blood becomes thicker and more difficult for the large muscle to circulate and pump the blood through the body effectively. So there are two types of hypertrophy that I'm going to talk about. These include concentric and eccentric. Concentric hypertrophy is thickening of the cardiac muscle and is more frequent than eccentric. It looks at increasing systolic contraction or increasing the force of contraction. Eccentric hypertrophy, on the other hand, is thinning of the cardiac muscle and happens because of increased blood volume in the ventricles. So in other words, there's less wall thickness and an increase in diastole volume and tension in the muscle. So here's a diagram that explains it very well. Figure A is a normal hypertrophy. When we look at diagram B in the middle, this demonstrates concentric hypertrophy. So it's clearly showing quite a thick muscle wall there. So there's a greater systolic contraction, but there's also less volume in there for diastole. So there's less filling, less blood being pumped out. When we look at diagram C, eccentric hypertrophy, it shows a very thin wall. So that's more room in the diastole filling, but there's less ability to contract the blood out of the ventricles, either going through the aorta to the body or to the lungs. So that diagram explains concentric and eccentric hypertrophy very well in a picture frame. So now that we've had a look at the sympathetic nervous system, the Starling principle, and ventricular hypertrophy, I just want to elaborate more on the cardiac functioning and how it's affected with these compensation strategies that the heart does. So the first thing we've got here is pulmonary edema. So that's your fluid in the lungs. This occurs because the fluid gets into the alveoli, and that stiffens the lungs, making it harder for the lungs to expand. The fluid in the lungs also interferes with how the oxygen gas exchange works at the capillary level. So that's one effect, not just on the pulmonary system, but also affects the cardiovascular system too. So the next one is dyspnea, which is shortness of breath. So this one is a consequence of a compromised cardiopulmonary system, causing reduced oxygenation in the blood that's returning to the heart. So the person here will experience great shortness of breath, either at rest or with exertion. Another effect is the depleted oxygen supply in the blood to the extremities, so to your ligaments, to your hands and your feet. This causes cyanosis. Cyanosis is the evidence of less oxygen reaching the extremities, and that causes the bluish coloured skin. And the final one I'm talking about is fluid retention. That occurs and can manifest through peripheral edema and pulmonary edema. So these are just some extra outcomes that occur that affect the body in the cardiopulmonary system as well as the body in general. So now we'll have a look at the practical applications. So the first one is very obvious, and that's your exercise therapy. So according to Swain, moderate intensity aerobic exercise is a proven intervention to assist in exercise tolerance. But this prescription of exercise is dependent on the etiology of heart failure. So as a guide, it is recommended that they cap the intensity to 60% of the heart rate reserved. And generally, with people with extreme heart failure, are recommended to exercise in smaller bouts with less intensity. So your next one is your pharmacological treatments. So obviously, as an exercise physiologist, you can't prescribe these, but you can definitely recommend your clients to get a prescription of these. So diuretics, ACE inhibitors, angiotensin 2 receptor blockers, beta-adrenic blockers, and dioxins are 5 common main pharmacological treatments that are out there for clients suffering with heart failure. All of these prevent acute heart failure and manage chronic heart failure. So a third application is oxygen therapy. So there's 2 types here. So you can have continuous positive airway pressure or bi-level positive airway pressure. Both of these methods in oxygen therapy are used to assist in heart failure and are mainly used for acute heart failure. However, this method raises the oxygen levels in the blood, which is what we want to happen anyway. So the fourth application is recommending cardiac resynchronization and implantable defibrillators. So what this is a pace is implanted that adjusts the ventricular contraction, which helps the functioning and pressure regulation. It decreases mortality of the patient and increases their quality of life. When heart failure is severe, patients are at risk of sudden mortality, and this leads to getting a cardioverter defibrillator implanted. This monitors the heart rhythm and sends electrical impulses to stop any unwanted arrhythmias or increases in heart rate. And the fifth one is a heart transplant, which is recommended for clients who are at the final stage of heart failure. The final application is to advertise on diet and restrict sodium intake. So some doctors will advise diet and limit fluid restriction regimes, and it is recommended that sodium intake in diet should be restricted anyway. So today's session, we've looked at heart failure, the compensation strategies, and applications for exercise physiologists. So your take-home message that I want you to walk away with is to know of the compensation strategies that the sympathetic nervous system, the RAAS, the Frank-Starling principle, and the ventricular hypertrophy have on the body. All of those acutely and slowly stop heart failure, or try to stop heart failure, but they're not long lasting. Eventually, these systems will fail, and that will bring about ischemia, cell death, increasing enlargement in the muscle itself, and reduce cardiac contraction, causing more and more heart failure. So that's the take-home message I want you to walk away with. So I hope you enjoyed this presentation, and I hope you learned a great deal about chronic heart failure and how it affects the body.